diagnosis. And so we're particularly pleased to welcome Dr. Danita Velasco today, who is Assistant Professor of Pediatrics and Genetics from the University of Nebraska. And she's going to be talking about the Dysmorphology exam for skeletal dysplasias. Dr. Velasco, we're so pleased to welcome you.
Thank you so much for having me. Let me go ahead and I will share my slides. And switch it over. Okay, hopefully that's showing up okay. So I'm very honored to be here and appreciate it very much. I'm a clinical geneticist up in Omaha, Nebraska. And so my role here is talking about dysmorphology for skeletal dysplasias. I do want to point out I have no financial disclosures, and because this is a dysmorphology discussion, I do have a lot of pictures, and these pictures are coming from textbooks, quite literally. Is that still showing up okay for everyone?
Looks great, thank you.
Okay. I think I changed my view. Give me 1 second. Okay. So today's topic, we'll be going through just what is a dysmorphology examination, and through that kind of working head to foot, pointing out some useful examination pearls, particularly in the context of skeletal dysplasias, and then briefly review some features of select and more common skeletal dysplasias. So by definition, what is dysmorphology? In 1966, David Smith, who's widely regarded as a father of dysmorphology, described this as the study or general subject of the abnormal morphogenesis and development of different tissue forms. This then evolved into kind of a small nucleus of clinicians who are experts in dysmorphology to a more broadly and widely recognized discipline. But there are key tenets to this that are pertinent to everyone and include kind of a head to toe exam and using really precise language. So whether or not you call it that, everyone does dysmorphology to some extent. To provide just some useful references that are available internationally, there's an Elements of Morphology series that was put together by one of these smaller groups that gave some of this precise language, which can be helpful when you're identifying and classifying different findings on physical examination. So this website will link to that and have this definition and description of these terms. So in looking at this examination, it really does start as a general exam. And what are you seeing on this general exam, which starts from kind of your gestalt walking into the room, and even before you walk into the room when you're reviewing what those growth curves look like. And as a geneticist, I really love growth curves. I love looking at them over time. I love looking at them in comparison to each other. So for individuals with skeletal dysplasia, growth plays a big piece in part of what that examination is including. And we look at the timing of when concerns about growth arise. Is this something that comes up in a prenatal context where there's concern about shortening of long bones? Is this something where there was normal growth and normal relative proportions at birth and then arose later on in childhood? And kind of sorting out that piece from timing. And then we look at different aspects of your growth in comparison to each other and in conjunction with each other. So in this model growth curve off to the side, there's a number of different things happening. I know it's very busy, but you can see along the top of the slide, the top dots would be something you would see in the context of someone who has like a familial tall stature. And you can determine if this is appropriate growth looking at things like the mid-parental height and seeing if that is consistent with what you're identifying for your patient. Then if we move down to the middle set of dots, you can see this person is growing typically for stature until they reach a certain age, and then they kind of level off rather abruptly. And so my question in looking at that would be, what's happening with my other growth parameters at that same time? Because that could be an important clue on, is this someone who needs more of a genetic workup, or is this someone who needs more of an endocrinologic workup? The bottom set of dots that are there show someone who's always growing at the same rate, same velocity, but always a little bit below the curve, kind of falls away from the curve as people are going into their adolescent growth curve, and then keeps growing a little bit longer, and overall ends up with a typical stature, as we can see in a constitutional growth delay or a short stature. And then finally, the stars, blue stars at the bottom, kind of give it away that this is maybe something that would catch your eye a little bit more, where you started with a smaller stature and the growth velocity has never been quite the same. But again, looking at what that growth looks like compared to not just height, but weight and head circumference, I think would be really important. So another piece with this that we often do from a genetics perspective is comparing these different growth parameters to each other in an individual who is below the growth curves on all parameters. So it's a more meaningful number to know not only are you below the 3rd percentile of your height and your weight, but your size is at the 50th percentile for what age. And so you can do that by taking wherever that mark is for the age and then moving backwards on the growth curve down to where it matches up with the 50th percentile and looking down then to see what age that correlates with. And so identifying in this example that this person at 13 years old is the height of your standard nearly 10-year-old and has the weight of an 8-year-old can give you some clues on what to think about and what might be contributing to their growth concerns. And again, I don't have any growth examples of growth curves for head circumference, but I think that would be another one where it would be a really key measurement to include in looking at this. In general, we think about disproportionate growth being more concerning for a skeletal dysplasia as opposed to a very proportionate growth. And when we look at that disproportion, it can describe a lot of different things. So disproportion from head, where that's a larger head, and then body size being smaller. Disproportion looking at different body segments, or even disproportion in the limb segments themselves. So the body segment discussion is tricky. So we know that our relative proportions for individuals change over the lifespan. And if you look at what percentage of your body is comprised of your head versus your trunk versus your limbs, that again changes as people get older. So the bottom picture is from the Hall book on growth, and it shows, prenatally, vastly different proportions compared to your adult age. And so just keeping that in mind as you do these evaluations and kind of these rough measurements can be helpful. One measurement that's particularly useful in the context of skeletal dysplasias can be looking at the upper segment versus the lower segment. And so to determine that, you have your tidal height, your total height from your head all the way to your feet, and then you can measure your lower segment, measuring from the top of the pubic symphysis down to the medial aspect of the heel. And to find your upper segment, you then subtract the lower segment from your total height. And this gives you a sense of your trunk length versus your limb length. And so in looking at the different skeletal dysplasias and different conditions, it's a rough measurement, but the ratio of your upper segment to your lower segment can give you a clue towards, is the shortening occurring more in the trunk, or is this more of a short limb, short stature that we're seeing? Again, you would want to use the right ratios for age. So in a newborn, as you can see below, the head is relatively larger, and therefore your ratio is 1.7. You come to a ratio of about 1 in early childhood, kind of that early grade school age group. And then into adulthood, the ratio goes down just a little bit more. So that typical is about 0.95. So for individuals with short limbs, then you see that the upper segment is relatively larger than the lower segment, and therefore your ratio increases in that upper to lower segment ratio, and vice versa if you are looking at something where there's more truncal shortening compared to limb shortening. Another measurement that can be helpful in just giving that gestalt sense of what proportions are would be a wingspan, where you're measuring from the tip of your middle finger to the tip of your other middle finger going across the chest and comparing that to your total height, because that's usually approximately 1 as well for that ratio. In individuals, particularly those who you identify as having limb shortening, you can look at, is there a particular part of the limb that's more involved? And so the terms that we use, again, in dysmorphology, where we like really precise terms, is looking at kind of 3 different parts of the limb. And this applies to upper extremities and lower extremities. But you can have rhizomelic shortening involving the part most proximal to the body. So humerus, femur is more involved than your ulna and radius. And then similarly, mesomelia is where shortening is occurring more in the forearm region, or kind of the lower tibial region. Micromelia describes shortening of all structures, and then not pictured here, but one that's used. Acromelia is referring to more severe limitations in shortening in the distal part of the limb. So moving into the exam features, and again, these are giving kind of general ideas of just what these terms would be. When you look at the head, as you walk in the room and you're just looking at your patient, you can get a pretty good sense of what is the relative size. Is there something about shape? And then that shape feeds right into, is there anything you think about cranial sutures a little bit more? And so macrocephaly versus microcephaly, again, I like growth curves, so I like to plot those all the time and just see what's going on. And you can see that the first individual has a large appearing head, has a taller forehead, and kind of has this longer looking head as well, whereas the second individual who has microcephaly, the forehead slopes backwards, the ear looks relatively larger compared to the size of the head overall, and therefore consistent with this being a smaller head size. When we look at the shape, we know that there are a lot of factors that can influence head shape, and we look at head shape a lot in infants and in young children. And so part of this that's influencing that head shape has to do with the cranial sutures and if there's any abnormalities to fusion of the cranial sutures. So the graphic in the middle shows what is typical, where you would have your anterior fontanelle connecting to your posterior fontanelle along the sagittal suture. Then you have the coronal sutures along here and lambdoidal sutures in the back. If you, there's a metopic suture, which goes down the front right in between the forehead. And if you have severe and very early fusion of any suture, then you limit growth along that line and your head compensates by growing along other lines. And that's where we have craniosynostosis with these distinctive head shapes that go along with it. So premature fusion of the metopic suture, you can end up with trigonocephaly. And here you can see when you're looking down from the above the head, looking down on it, you can look at the head shape and see that there's a little more of a triangular point in the forehead. Above, in like the 11 o'clock position in this picture, it shows a long oval head shape that doesn't have the typical width associated with it, and that would be consistent with dolichocephaly or scaphocephaly when there's sagittal synostosis occurring. We do see, a lot of babies who are born really preterm and with positioning sometimes have more of that dolichocephalic head shape without necessarily having premature synostosis. But where you have sagittal synostosis, you can have a more pronounced shape and even more of this keeling formation to the front forehead and occiput, that would be consistent with scaphocephaly. The next picture at like the 1 o'clock position shows a shorter head length from anterior to posterior measurements, and this would be consistent with brachycephaly. And then a very severe finding would be this last picture where we have fusion of multiple suture lines consistent with a cloverleaf synostosis. And so that's a very distinctive finding and has a particular differential diagnosis, of which the nataphoric dysplasia would be one of the ones on the list, depending on timing for that. So as an example, here you can see two very cute babies. The first baby labeled A, as you look from the side, not looking down, but that longer head shape where you have sort of heel of a boat shape to it that's consistent with scaphocephaly. And this is the CT reconfiguration from that individual that shows that premature fusion of the sagittal suture. And this can be a finding that goes along with some skeletal dysplasias. There were no other findings for this individual, but it does describe in the context of things like X-linked hypophosphatemic rickets, you can see craniosynostosis, and then it can involve the sagittal suture, other sutures. Hypophosphatasia would be another skeletal dysplasia that can present with craniosynostosis as a component of it as well. The baby down here on the bottom, just looking at her from a general sense, you can tell that her head, just by default, appears larger compared to the rest of her body. It may not jump out quite as much, but her limbs appear a little bit shorter. And in looking at her head and her face shape, that forehead is pretty large and pronounced with a relatively depressed nasal root. So it's already starting. It's hard to separate the head from the face, but when you look at someone, you move automatically into that gestalt for their face, and that can involve describing what is the face shape that you see, what are features about that face, how finely wrought are those details, how much is there coarsening or changes going on there. And so this first line of pictures, you can see the first baby has a very round face, and it's more broad than it is long, so kind of a short face. And what's contributing to that, again, if you really broke it down for yourself, you look and say, okay, well, there's minimal chin contributing to this. And so this is why this face looks so short. whereas the middle child in the top row of pictures has a broader forehead, a taller forehead, and then it kind of slants down to a very narrow and pointed chin, just like the patient right next to him. This is not anything that is a distinctive single gene, single syndrome that goes along with this triangular shaped face. This is something we can see in a lot of conditions, but it can be helpful in just identifying that. And we do see this in skeletal dysplasias as well. The last picture set on this top row is two siblings where the little boy who's pictured first is older than the second child there, but has this distinctive inverted triangular shaped faces and poor growth, and has Russell Silver syndrome, where you can see his sister does not share necessarily the same features and has a similar height, even though she's quite a bit younger. On the bottom row, this is giving that sense of facial gestalt. And the biggest thing probably to take away is just having an idea of what coarsening of the features would look like. And so this is where you've lost some of the definition around the nose and the eyes. The features are less delicate. There's apparent thickening of the tissues. And so, of course, in individuals who are presenting with distinctive skeletal changes, especially those involving vertebral bodies, you would not want to miss someone who has a treatable condition. And so storage disorders like mucopolysaccharidoses and mucolipidoses come up as considerations in this. However, there are other conditions that can present with coarse features. So it's a very pertinent exam feature, but not by itself diagnostic. We can look again, still looking at the face, and get kind of a general sense of what is the profile of the face, because identifying just the shape on profile can give you some good clues about things as well. And then again, those relative proportions when you're looking at just the face itself. So the first baby you can see looking kind of from here, the glabella, this middle part in the forehead, along the malar region. This is this middle area that's medial to like the zygomatic arches underneath your eyes, and then down to the chin. You can tell this baby is micro retronappia. And that is what gives that very concave facial profile. The second individual labeled A, when you look from the front, there's not anything that really jumps out, but then when you look on profile, if you draw a line from the glabella down to the tip of the chin, you can see that there's really not any of that typical curvature to the facial profile. And this is consistent with a flatter facial profile or in the malar hypoplasia underdevelopment that we can see in some of the connective tissue disorders or abnormalities of collagen 2 in particular can present with this finding. And then again, it kind of goes along with just assessing that profile view. You can see in the bottom pictures that more than flattening, there's actually a little bit of protrusion in the bottom picture where the midface goes back behind the level of the glabella more so. And so that midface underdevelopment, midface protrusion is identified there. And we can see that in some skeletal dysplasias as well. So eyes, I look at eyes a lot in the context of dysmorphology overall, and there's a lot of different terms that you can use in describing the eyes and the eyelids and placement and different features about the eyes. To define it, when we look at eye placement, we're looking at where certain landmarks are relative to each other. So the inner canthi versus the outer canthi, where they lie. And then you also want to look at what's the distance between your mid-pupillary line. And then this is with the eyes facing straight forward if you were to measure between there and what distance that is. And we use those to then help us in describing different placements. So hypertelorism or hypotelorism has to do with what is the distance between the pupils themselves. And there are growth curves, if you will, for measurements for this. I often, again, will do this based sort of on a sense of if it looks appropriately proportioned, and if someone has a typical palpebral fissure length, how close do the eyes appear to each other. Things like epicanthal folds, where the inner part of the eye, you can see it in this top picture where there's down slanting palpebral fissures, but there are epicanthal folds as well, comes across. These can be a very typical finding and not in and of themselves a cause for concern given the background of the individual and the family. But with epicanthal folds, you can have decreased distance between the inner canthal distance and still have normal interpupillary distance. So you could have normal telorism, even though your telecanthic distance is different. Again, looking still at those inner and outer canthi, you can look at the slant between them, just looking from inner to outer. And if it slants downward slanting palpebral fissures and up is upward slanting palpebral fissures, you can get a sense subjectively of the eye placement within the face, and if it is deeper set or if the eyes appear relatively prominent. And like there's evidence of proptosis, which would be another one of those clues toward could there be underlying bone changes here, or a craniosynostosis picture where you would want to consider that as well. I don't have a picture of it, but one other thing that often comes up in the context of skeletal dysplasias and looking at your eyes, paying attention to scleral color, and if there would be signs that would be suggestive of OI with that bluish sclera. Again, that's not present in every individual who has OI and can present in other conditions besides osteogenesis imperfecta. When we look at the midface, and the nose is a prominent feature in your midface, and so again, another part where it's hard to totally pull them apart. There are terms to describe different parts of the nose. I think key things you're looking at are what's the root, how is it positioned, what does the nasal bridge look like, and then how would you describe the nasal tip? And so here are some good examples where the first baby, you can see that there is a depressed nasal root. It is back behind the level of the glabella. It's a short nose when you look at the nasal bridge and the somewhat upturned nasal tip associated with that. The bottom series of pictures looking straight on, you see that there's a short appearing nose, and then when you look on profile, that the nose does not have the typical amount of extruding from the face, and is a hypoplastic nasal ridge, hypoplastic nasal tip where it's overall just underdeveloped. And that can be a very helpful clue in looking for certain conditions of those, the Achondrodysplasia punctatus with stippling of the epiphyses as a key feature that's present when you do x-rays early on in life and can disappear over time, or other conditions that impact vitamin K metabolism can also present with that kind of distinctive finding. And then the last picture shows a little boy who has a somewhat broad nasal root. The nasal bridge is also broadened and maybe appears a little bit more relatively pronounced because the alae nasae, the nostrils, are underdeveloped so that you get this kind of bulbous looking nose overall. As you move down from nose to the oral cavity, there's a lot of things that can come along with this. So there are some conditions where it's very helpful to pay attention to how many frenulum are there. You have the typical oral frenula between the upper lip to the gum line, the lower lip to the gum line, and then under the tongue. Do you have the typical number of teeth, or are there extra teeth or missing teeth? And then looking at the quality of the teeth. Do you have pits? Do you have recurrent abscesses or other cystic changes to the jawline? And then what's the enamel like? Are there changes there? Because again, that can be a good clue in helping you work through that differential diagnosis. The palate is another key structure. There's more of an association with cleft palate and skeletal dysplasias than cleft lip and palate, although there can be some skeletal dysplasias that can involve cleft lip and palate, particularly if there are other ectodermal changes that go along with it. When you look at the palate, you want to describe what are you seeing. So this is a picture of a cleft palate that involves both the soft and the hard palate. And towards the tip of that unrepaired cleft, you can see that it's not sharp V shape, it's more of this gentle kind of U-shaped curve. And so in any child who has micrognathia that you're picking up on exam before you see them, you want to pay extra special attention to that palate and make sure that there's not evidence of Pierre-Robin sequence where you have posterior displacement of the tongue that's interfering with closure of the palatine ridges and then contributing to this cleft palate with likely respiratory distress in that context. Because again, those sorts of chin and palate abnormalities can be associated with specific conditions. The ears are a tricky structure, I would say, for dysmorphology in general, because there's a whole lot of variation in what's typical ear development and what's atypical. But things that are a little bit more clear and important, particularly in the context of a dysmorphology exam for dysplasias, would be evidence of microtia. So microtia occurs in different gradients, but we know that we can grade this 1 through 3. This would be like a grade 2, where the ear is smaller and has abnormal external pinna structures. But if you have someone who has small stature, smaller head size, and microtia, then on exam or things for further workup, you'd want to know about the patella and see could this be something consistent with the Meyer-Gorlin presentation. Similarly, another one of those kind of important ear changes that are truly textbook, as these images come from textbooks, would be if there are cystic ear changes. And so in the very bottom corner, it shows that newborn initial cystic ear change, which will involute over time and leave you with this kind of cauliflower ear change. And this is one of those findings that's identified in dystrophic dysplasia. Finally, when you're looking at the limbs, we've already described those different proportions, rhizo, meso, acromelia. You can look at angulation. Are there changes to how the limbs lay? And I feel like this is probably something that's better described by many of the orthopedics than I am, and helpful to have radiographs along with that. In the upper extremities, the first picture shows where there's this sharp step off at the wrist, which is something that can be associated with a Madelung deformity and is a good clue. And so if you're seeing someone who has a disproportionate short stature with mesomelia, involvement of the shocks region on chromosome X is a good consideration. If this is a girl who maybe doesn't have disproportionate short stature but has slow growth and presents with a Madelung deformity, you would not want to miss something like Turner syndrome, because that would have broader implications to her overall care. As you move into the hands and the fingers, so there is a whole area of dermatoglyphics where you're looking at what is really going on with the shape of the finger whorls and curls. I don't know that I know of any of those specifically that are pertinent in particular to skeletal dysplasias, but things that do come up, you're looking at what is the relative size of the palm to the fingers to the rest of the arm. And then you're looking at the fingers. Are these shortened fingers overall consistent with brachydactyly? Are there abnormalities to the nails or to the shape of the distal finger? Are they kind of spoon shaped or broadened and flattened? Is there one digit that's different from the other ones? Are you noticing that the thumb is placed in an abnormal position? Is the thumb triphalangeal where it almost looks like another finger? Is the thumb absent? Those sorts of things. And then when you look at the hand overall, is this a shorter, broader hand? Do you notice that the way the fingers are positioned always favor a certain kind of conformation where you're grouping fingers together a little bit differently? So this middle picture is a picture of a hand of an individual who has achondroplasia, and you can see that there are those shorter digits and then this increased space and kind of this 3-part grouping of the fingers consistent with the trident hand configuration, or starfish hand, or that's another term sometimes used. And then the baby at the very end, if you're looking at her left hand, you can see that the thumb comes off at a more abrupt angle and is fixed like this. And that would be that hitchhiker thumb that can be seen in dystrophic dysplasia as well. So that was a really fast overview, and there are a lot of body systems that I know I skipped over in the interest of time, but just to review some high yield conditions and kind of put those findings together. Achondroplasia is the single most common skeletal dysplasia, and you would see rhizomelic shortening with disproportionate stature, relative macrocephaly associated with that. There's frontal bossing where the forehead again is more pronounced, and when you look on profile, you can see it extending beyond the facial plane a little bit. Nasal root retrusion and the shorter nose can go along with it. And then that trident hand configuration, which can be a really helpful clue as well. For the type 2 collagen-related disorders, this is a bundle term, and it's talking about a lot of different conditions that all have the underlying molecular cause related to changes in the collagen 2A1 gene. And so there's varying degrees of severity, but some features on dysmorphology that are pertinent to know about and kind of look for when you're seeing this would be that facial profile. Are you seeing that flattened facial profile? We know that type 2 collagen is important to the vitreous humor of the eye. And so individuals who have changes in and deficiencies in the amount of type 2 collagen are at risk for having retinal detachment and this distinctive pattern on ocular exam and a high degree of myopia that can present very early on. So a family history of severe myopia with other features suggestive of a skeletal dysplasia would point you towards thinking about this a little bit sooner, and also help you if you're thinking about this to make sure that your overall care for the individual includes that early ocular screening and intervention if there are concerns. You can see, as I've mentioned before, micrognathia, Pierre-Robin sequence with cleft palate occurring frequently in these conditions as well. And then finally, I didn't talk about it in the dysmorphology piece, but you're also looking at ectodermal structures, which include your hair. So for this individual, are you noticing abnormalities to the amount of hair, the texture of the hair? Is it very fine and sparse and relatively deficient, which in conjunction with shorter stature and metaphyseal changes might lead you to asking more questions about, signs of immune dysregulation or recurrent infections, and that together would make you think about a cartilage hair hypoplasia. I think another condition that's not a skeletal dysplasia, but can present with shorter stature, some distinctive craniofacial features, and really distinctive hair changes would be a Noonan syndrome or other rasopathies. And so that's probably a good one to have just in mind on your differential as you see people as well. And then with that, I will turn it over to the host.
Wow, that was extraordinary. Thank you so very much. I will never look at my neighbors quite the same way again. That was terrific. Now,